I think there are quite a few people online, and the studio is filling up as well. So, dear Xavier, a very warm welcome on this Sip of Science webinar. And to be in style, I have a cup of coffee to have a sip, but you provide the science. And dear guests, those of you in front of your screens at home, and we have a lot of residents here in the studio. So Professor Monnet is one of the key figures in haemodynamics and especially in fluid responsiveness. And possibly it's not exaggerating to say that most of the things that we know about fluid responsiveness, it comes from this group, this team, founded by Jean-Louis Teboul, and Xavier was and has been, working side by side with him, and we know each other for 20 years. So Xavier, it's a great pleasure to listen to your talk, which is always fantastic. So the stage is yours, my friend. Please share your thoughts with us.
Thank you very much. Thank you, Joel, and it's a great pleasure to be with you today. Indeed, to speak about fluid, but I would like to see with you to speak with you about the issue of fluid balance and the reduction of fluid balance in septic shock patients. And I first, of course, disclose my conflicts of interest, especially with Palchan Medical Systems and with Baxter for this presentation. What are we speaking about? We can speak about that very practically. At day one, for instance, we have a patient with a septic shock, typically on community-acquired pneumonia. And of course, the first treatment administered to this patient will be fluid infusion, fluid resuscitation. But today, in 2024, we are all concerned about the fact that this fluid infusion may contribute to fluid accumulation, to increasing the total fluid balance. And I would like to deliver 3 messages regarding the fluid balance today in septic shock patients. The first is that fluid accumulation is definitely harmful in critically ill patients. I mean that we have many studies describing the harmful effects of fluid accumulation, of fluid overload in different systems and tissues. You all know that it increases abdominal pressure, it promotes acute kidney injury, it increases the risk of right ventricular failure, it induces hemodilution, and most of all, it increases lung edema, aggravates lung edema in patients with ARDS and lung impairment. And as a consequence, you all know that today many studies confirmed that increasing the fluid accumulation is harmful. This is true in all critically ill patient populations, especially in septic shock patients, in ARDS patients, in patients with acute kidney injury. That's only one of the studies, but many studies have confirmed the risk of increasing fluid accumulation, of increasing the fluid balance, the total fluid balance accumulated during the ICU stay. In spite of that, many studies that have confirmed a reduction of the fluid balance, a restrictive fluid strategy, compared to a liberal fluid strategy or a conservative fluid strategy compared to a liberal fluid strategy, have been negative. And this is the reason why some experts say, okay, there is no need to take into account this fluid balance. It is not justified to reduce the fluid balance in septic shock patients because we have no evidence that it may be beneficial in terms especially of mortality in our septic shock patients. Despite that, I think, and it is my main message, that reducing the fluid balance is not only possible, but it should be active and personalized. What do I mean? As you know, this fluid balance is made of the fluid that you give initially, that's called fluid resuscitation, the fluid that is needed sometimes at the optimization, stabilization phases of septic shock. You know this ROSE concept of septic shock resuscitation, and of the fluid that you may remove at the evacuation phase. And as this fluid balance is directly linked to the risk of dying and to harmful effects, likely a mantra for taking care of these septic shock patients today would be to reduce the area under this red curve, to reduce this total fluid balance, this accumulation of fluid. And of course, it may start with fluid resuscitation, the first bolus of fluid you give to your patients. If you follow the recommendations of the Surviving Sepsis campaign, as you know, you should give 30 milliliters per kilogram within the first 3 hours. I think with others, and we wrote, for instance, this position paper with Jean-Louis Vincent and others, that we should not individualize the fluid resuscitation only on the weight of the patient. We should not use single formula. And I think this is absolutely obvious. Why? You all agree that this initial fluid resuscitation in septic shock is made for compensating for relative hypovolemia created especially by venous dilation and for absolute hypovolemia resulting from fluid losses. But it is obvious that this absolute hypovolemia is different depending on the patient. Of course, it will be larger in a patient with peritonitis, for instance, compared to a patient with community-acquired pneumonia. It will be larger in a patient with larger fluid losses than in a patient with no fluid loss. That's obvious. And so this is why this initial fluid resuscitation should not be the same in all the patients. 30 milliliters per kilogram is not justified. And by the way, this is what we show in this study, which is not published at the moment, be careful, where we reviewed the volume of fluid which is necessary in septic shock patients depending on the shock origin. And so we measured the fluid volume that was administered until the patient became fluid unresponsive. And we said, okay, that's likely the fluid that was needed initially. And not surprisingly, you see that the volume was larger in patients with abdominal sepsis compared to patients with lung sepsis, for instance. But even more, so it is highly variable. And more interestingly, you see that on average, this fluid volume that was necessary for the initial fluid resuscitation was 30 milliliters per kilogram on average, but it means that it was too much in half of the patients and not enough in half of the patients. On the contrary, if we use the 10 milliliter per kilogram fluid resuscitation at the beginning, almost all the patients remained preload responsive after fluid infusion, suggesting that this should be the initial fluid volume that is required by the patients. Then you may give fluid to optimize the fluid status and the total blood volume. At this stage, after this initial fluid resuscitation, obviously, a way to reduce the cumulative fluid balance is to give no ineffective fluid. I mean, to give no fluid in patients who are preload unresponsive. We should individualize the fluid administration depending on the needs of the patients, of the physiological needs. It's not my purpose today to review the tests and indices of preload responsiveness that we have today, but I would like just to insist on one point. This detection of preload responsiveness should occur rapidly. We have some data today telling us that preload responsiveness disappears rapidly. That's a very interesting sub-analysis of the Andromeda shock study, with the study with capillary time. All the patients, the black bar, were preload responsive at the beginning after initial fluid resuscitation. All of them, 100%. You see that 2 hours later, only 2 hours later, only 40% of the patients were still preload responsive. Preload responsiveness had disappeared in 60% of the patients. Fluid infusion may be inefficient in 60% of the patients. Fluid responsiveness disappears rapidly, so not only we should test it to avoid ineffective fluid infusion, but moreover, we should assess fluid responsiveness rapidly. And we have some studies today, that's the list here, I do not show the detail of all these studies, showing that if you test preload responsiveness, especially early in septic shock patients, you reduce the fluid balance. It was the case here. Very early in the course of septic shock, these colleagues tested preload responsiveness with passive leg raising test from the emergency department and observed a significant reduction in the total fluid balance of these patients. I mean, it works for reducing the fluid balance. A second way, so you see that's a way to personalize fluid therapy. I insist on this issue of personalization. The second way to reduce the fluid balance may be to increase fluid efficacy, and this may be achieved by considering early norepinephrine administration. Indeed, the next treatment that will be administered to this patient is norepinephrine. But the question today is, when should we start norepinephrine? Should it be earlier than before? And indeed, if we speak about fluid accumulation, when we give fluid to our patients, it is basically because of its arterial effects. We expect that norepinephrine will fix arterial alpha receptors and induce arterial vasoconstriction and increase blood pressure. But also, bear in mind that there are some alpha receptors on the veins, especially alpha-2 receptors. And that norepinephrine, when you give norepinephrine also fixes these venous receptors. This induces significant venous constriction. And this effect may be to recruit a part of the volume of the venous blood volume that is unstressed. You know, this unstressed blood volume of venous putin. When you give norepinephrine, you reduce the size of the venous reservoir, and so you increase this pressure, which is called the mean systemic pressure, which promotes venous putin. And so you may increase cardiac output. So you understand, when you give norepinephrine, you may exert a fluid-like effect to increase the pressure in the venous reservoir that is upward the venous putin. Not only this may be an additive effect with fluid infusion, but you may even decrease the needs for fluids afterwards. I mean, that's once you have given norepinephrine, you've started norepinephrine, the size of the reservoir is reduced, and so the next fluid infusion you will give to your patient will be more efficient on this mean systemic pressure. It will not dilute in a large dilated venous reservoir. It may be more potent in a constricted venous system. And that will be a synergic effect of fluid infusion. It would increase mean systemic pressure to a larger extent than without norepinephrine. And we don't share the results, but we performed some studies showing that indeed, when you give norepinephrine, you increase mean systemic pressure and you reinforce the effects of fluid infusion. And of course, this may lead to giving less fluid to patients where you give norepinephrine early. Some study, we had very few data in randomized controlled trials, but with prospective studies like this one showing that if you start norepinephrine very early, you see within the first hour after the beginning of septic shock, you reduce fluid administration and you may decrease 28-day mortality, suggesting that giving norepinephrine early may be beneficial for reducing this fluid balance. But of course, it should not be the same in all the patients. It may be particularly helpful in patients with strong vasodilation, indicated, for instance, by a low diastolic blood pressure. You know that the DAP is a good indicator of the arterial tone, much better than the calculated systemic vascular resistance that likely we use every day. A low diastolic blood pressure, for instance, below 40, indicates a low arterial tone. It may be also this diastolic shock index, heart rate divided by DAP, which, when it is high, indicates, again, a arterial vasodilation. Not the same in all the patients. For instance, in a patient with severe septic shock, soft tissue necrosis, with previous calcium inhibitors administration and strong septic shock, with a strong vasodilation indicated by a low diastolic pressure, a high diastolic shock index, you should start norepinephrine early. In a patient with a less severe septic shock, for instance, a urinary tract infection with less arterial dilation, you may wait fluid resuscitation, after fluid resuscitation for starting norepinephrine, not the same in all the patients. A third way likely to reduce the fluid balance may be not to give fluid when the risk is too high. And I think that that's a step that is often missed by some colleagues. I mean that you should have in mind some indices, some variables that tell you, no, the risk is too high. No, you should not give fluid anymore. I don't have time to review all these indices, but for instance, if the fluid balance is very high, it's not very specific, don't give more fluid. If the intra-abdominal pressure is high, the same. If the PF ratio is very low, not very specific, neither very specific. If CVP is high, if pulmonary artery effusion pressure with the pulmonary artery catheter is high, if the lung water you measure with the transpulmonary hemodilution is high, then you may say to yourself, okay, the risk is too high, I do not give fluid to my patient. Again, that's a way to personalize. A patient with pneumonia and ARDS with a CVP of 10, not very elevated under mechanical ventilation, with a lung water just above 10, which is the normal value, you may give fluid. On the contrary, on a patient with a high lung water value, with a very high lung permeability and high CVP, you should not give more fluid and, for instance, decide to increase the dose of norepinephrine for restoring haemodynamics. Again, not the same in all the patients. One crucial point to reduce the total fluid balance should be to avoid unnecessary fluid infusion during the later phases of septic shock care. I mean, to reduce as much as we can the fluid we give for maintaining, the lines open, for nutrition, for diluting the drugs, etc. What some call the maintenance and the creep fluids. That's very important. Why? In this study, which is one of the most interesting published in the field of fluid therapy, these colleagues reviewed all the fluid administered in ICU patients in a large population during a high number of ICU days. You see that this maintenance and fluid creep represented half of the fluid we give to the patients without knowing that we give fluid. Again, that's fluid that you give just for nutrition, for diluting antibiotics, etc. Reducing this fluid amount is very difficult because it means that you should change your practice for nutrition, for, again, drug dilution, etc. For reducing the flow of fluid you need to maintain the venous lines open. We are trying to do that in my ICU, for instance, and it's quite difficult, but a point to bear in mind. Finally, Of course, a good way to reduce the fluid balance is to remove excessive fluid. Consider fluid removal, but again, this should be individualized. What do I mean? Let's imagine the same patient, but now at day 7. And I think about reducing fluid accumulation by removing fluid. It's always the same question. How much fluid should I remove? For instance, the patient is ultrafiltrated. Which ultrafiltration rate do I plan? Is it, should I remove 2 liters, 3 liters, 4 liters? Because the risk is to remove too much fluid and create hypertension. To individualize this fluid removal, I suggest to test again preload responsiveness. What do I mean? That's what we tested in the study. We ultrafiltrated some stable shock patients at the end of the shock duration. And before ultrafiltration, we tested preload responsiveness by a passive leg raising test. And the idea was quite simple. If your patient is preload responsive, it means that when you will decrease preload with ultrafiltration, you will remove fluid, so you will decrease preload. Cardiac output will decrease preload responsiveness, and hypertension may occur. On the contrary, if your patient is preload unresponsive, he or she should be protected against a reduction in cardiac output with hypertension during ultrafiltration. And indeed, it was the case. You see that on this figure, preload responsiveness before ultrafiltration indicated a poor tolerance with fluid removal and a decrease in cardiac output and intradialytic hypertension in our patients. So again, a way to individualize, not the same in all the patients. In my patient, if passive leg raising is negative, I know that hypertension should not occur. There is no risk to remove too much fluid, and I should go on with ultrafiltration. I should not ultrafiltrate the patient with a positive passive leg raising. A mistake on the slide, I'm sorry. So again, individualize on the patient physiology, not the same in all the patients. So you see that I think that it is possible to reduce the fluid balance, but we have several ways to do so. And it is likely efficient only if you use all the different ways to do so, and if you personalize this reduction in the fluid balance, as I told you. Finally, the RCTs I quoted at the beginning, which tested a restrictive, a conservative fluid strategy compared to a liberal fluid strategy, were negative because they did not test such an active and personalized fluid strategy. Look, all these studies here, if you summarize all the different means I listed to reduce the fluid balance, never tested all the interventions together. One study only tested fluid removal. 2 studies only tried to reduce the maintenance fluids. No study assessed preload responsiveness. The majority of the studies focused, as you see, on fluid resuscitation. But in the study I showed you before, you know, the different amounts of fluids administered, fluid resuscitation represents only 6% of the total fluid amount administered to the patient. If you reduce only this fluid volume, of course, you cannot reach a large volume reduction. That's a summary of the different studies that, tested this reduction of fluid volume. And you see that indeed the volume reduction, the reduction in fluid volume administered to the patient was very small. And of course, the different reductions in mortality were very different and very small. The Clover study, the recent Clover study, induced only a small reduction by 600 milliliters not liters, but milliliters at day 5. And of course, this cannot reduce mortality. So definitely, it's not because of these negative RCTs on fluid restriction that we should not reduce the fluid balance, which is possible provided that you use an active and personalized fluid strategy. And with this last message, I thank you very much for your kind attention.
Great talk. I am really sorry that you finished so early, Xavier. You should have gone on for longer.
Well, I'm sorry, you told me it could be 20, 30 minutes. So
yeah, well, you are spot on as always. I never heard you overrun. Anyway, any questions from the audience here? Come on, residents. You have it will take a long time until you next can talk to Xavier in person.
No.
Yeah, might be next year. Might be next year in Seps East. Yeah, true.
Seps East, yes.
Yeah. Well, anyway, until you have a question, Janir? Okay, over to. Yeah, but they look shy, so over to you.
Professor Monnet, thank you so much for the exciting lecture. I have two questions that are connected to each other. So traditionally with fluid resuscitation, we focus a lot on the pump function of the heart and the arterial system. But in your opinion, what should be the role of intermediate treatments that ensure microcirculation and tissue perfusion, such as choosing an alternative vasopressor like levosimendan or dobutamine, or administering glucocorticoids to slow down the dysregulated inflammatory response, or co-administration together with a vasopressor, co-administration of direct acting endothelial agents like bosentan and prostacyclin. And in connection with this,
first I will answer the first question, otherwise I will not remember it afterwards. First of all, thank you very much for this question, which is indeed very interesting. I spoke only on fluid resuscitation, and you're right, there are other aspects of resuscitation of septic shock patients. Among these different means, you spoke about ways to maintain the microcirculation. Nevertheless, today, we do not have any well-defined means to maintain this microcirculation or even to improve the microcirculatory function. For instance, you mentioned levosimendan or dobutamine that are vasodilators and not vasoconstrictors. Bear in mind that dobutamine and levosimendan are arterial vasodilators. Even these vasodilators have not been demonstrated to improve the microcirculation in septic shock patients. And in addition, it remains that you will need some vasoconstrictors in hypertensive patients. So I mean that we do not have today, unfortunately, ways to improve the microcirculatory function that have demonstrated to be safe and to be efficient. And it's the same for bosentan, as you mentioned before, which, it's very difficult. Why? Because the microcirculation is not impaired by vasoconstriction or vasodilation. As you know, it's impaired by some functional aspects and also by some mechanical obstruction, okay? In any way, if you give a vasoconstrictor, and these patients likely need a vasoconstriction, you will in any way constrict the arteries. I mean, in any way, you will induce a constriction of the arteries before the microcirculation. And so we may imagine a treatment that will dilate without constricting, which I think is not the solution. The only way may come from a reduction of the inflammatory attack that would decrease the microcirculation impairment, inflammation around the microvessels, coagulation in the microvessels. I think that's the only way to improve the microcirculation, not by giving dilators or constrictors or different constrictors. Regarding glucosteroids, of course, you're right, that may be part of the treatment, especially to improve vasoconstrictive efficacy.
And what about the direct-acting endothelial agents like prostacyclin or bosentan?
As you know, it's never been tested, and again, finding a treatment that will act on the microcirculatory haemodynamic, that would not reduce the attack of the microcirculation and inflammation around the microvessels, I think will not be efficient. But again, this has not been tested until now.
And actually, my second question was in connection to this. There is an instrument called a handheld vital microscopy, which is something a little bit more complex than a capillary refill time physical examination. Do you think such an instrument has any future in the clinical research?
Thank you. Again, it's a very interesting question. You're a fan of microcirculation, by the way, but that's good. Huh? You speak about something that investigates the microcirculation directly, looking at the microcirculation under the tongue especially. So, of course, this is a much better way to look at the microcirculation than just the capillary refill time. By the way, I'm not sure that this capillary refill time is a good surrogate of a microcirculation variable. I'm sure it's not the case. And by the way, some studies have demonstrated it's not a marker of microcirculation. Is it interesting in clinical practice to look at the microcirculation? I'm not sure. And by the way, these such devices have been developed years ago now, and until now, no study has demonstrated that it's particularly helpful. And we are still at the same stage. And likely because, as we said just before, we do not have treatments that may act specifically on the microcirculation. So such devices, and by the way, it's not very easy to use them and to access the microcirculation with precision, help you to see more, but I'm not sure that they help you taking some specific therapeutic decisions. That's why they are not indicated for clinical practice until now.
In the meantime, I would like to encourage those in front of the screens, there are dozens of them, to ask questions either in the chat or the Q&A. In the meantime, if you have any questions, just raise your hand. I can see it on the screen. But I have two questions. One of them is personalizing fluid therapy. You mentioned, Xavier, the passive leg raising. And there are some issues with this because it's not easy to do. And you showed it in that drawing that you need a special bed, you need a special position, you need a monitor which measures pulse pressure or stroke volume variation. And there is an argument that I often receive from my colleagues on the ward that when you do passive leg raising, this is quite a stress to the patient. It is uncomfortable. So how can you? So would this kind of stress that the patient feels threatened, uncomfortable, whatever? So this sympathetic stress, this sympathetic hyperactivity, would alter the measurement in any way, or would it give a false negative or false positive signal on the test? What is your opinion on that?
2 points. First, of course, if there is sympathetic activation due to pain, let's say emotion, surprise, etc., this may create some false positives to the PLR test. In our studies, we did not observe that just looking at heart rate, but this was during clinical studies where, of course, we took care of preventing these events. So, of course, this may occur.
How do you do that in your everyday practice?
And so, the second point is this one. There are some limitations to the passive leg raising test, and this is one of the limitations, especially in fully awake patients. If the patient is sedated, one must say admits that it's not a big problem. Another limitation is that it's not very easy to perform. As you said, you need an electrical bed, which is not always available, etc. This is the reason why we have developed other ways to assess preload responsiveness, typically using the ventilator. And these different tests using the ventilator, if you stop ventilation at end expiration, we called it the end expiratory occlusion test. If you reduce the PEEP level, and we called it the PEEP test, these are ways to assess preload responsiveness that are easier to use than the PLR test. If I do the round in my unit this afternoon and I ask the residents, which test did you use in this patient, there are 99% of changes that he or she will answer, I used a ventilatory-based test, not passive leg raising, because of the limitations you said. Especially in awake patients. I mean, patients with but by the way, I'm not sure it's a big issue because these patients who are usually not ventilated are patients where the risk of giving too much fluid is not that high. The main issue of fluid, the risk of giving too much fluid is in ventilated patients with ARDS and lung impairment.
My other question is the fluid balance. I think it is often overemphasized at the patient's bedside. And why I'm saying that, because if there is day one or the first hours, and we give a lot of fluid because the patient is in absolute hypovolemia, so this fluid should be not taken into account 3-4 days later, because then somebody does the overall cumulative fluid balance, and it turns out that the patient is in 3 liters plus. But this is not the case. So what is your advice? How to use cumulative fluid balance, or should we use it at all, or just use the overall picture, like the macro hemodynamics, SCVO2, CO2 gap, lactate, and do a dynamic test rather than looking at the overall cumulative fluid balance?
First, it's true that if you look only at fluid resuscitation, you reduce only one small amount of the fluids you give to the patients. That's what I showed before in the Van Regen-Martel study, only 6% of the total amount of fluid. It's only part of it. So yes, I think that we should attempt to reduce the total amount of fluid we give. Not to observe these clinical pictures that we see sometimes with these very inflated patients with 15, 20 more kilograms. One sees in some ICUs where it's not a concern for the clinicians. So yes, one should reduce the fluid balance by using all the ways I told you before. Then, should we have the eyes only on the fluid balance? I'm not sure. First, because it's very difficult to measure. But having that in mind and trying in all the ways we have to reduce it, I think is a solution. I insist on the message. You said the majority of the fluid is administered at the beginning. I'm not sure, because look at the fluid you give during the next days, just by nutrition, etc. As I said, for diluting the drugs and just keeping the venous lines open, you will see it's a majority of the fluid you give to your patients. So yes, we should pay attention to it, not looking at the value of fluid balance itself, and bearing in mind that it's a concern not only at the beginning of hospitalization and care of septic shock patients.
Okay, any more questions? So no questions online. My final question is, what is your strategy, how to choose the type of fluid that you use for fluid resuscitation, or I dare to say maintenance, because that is a swear word in your algorithm now. So what type of fluid do you use?
I be very cautious, because today, if you speak about the type of fluid, it's like speaking about religion. You have enemies, and so. So for years, I used saline. I'm telling myself, okay, I will use, because the issue today in such patients is between saline and balanced solutions, right? That's likely your question. We do not use artificial colloids anymore. And so I said to myself, I give saline until I give really a large volume. And if it's the case, I change for balanced solutions. And I said to myself, if I give just a small amount of saline, I don't know, 2-3 liters for resuscitation, this will not induce significant hyperchloremia and impair the renal function. Nevertheless, I have changed my mind, considering the fact that it's true that small amounts of saline do not induce hyperchloremia, acidosis, and renal failure, but it induces significant sodium overload in any way. And so today I give more balanced solutions, considering the risk of sodium overload. I've been convinced by the fact that sodium overload induces fluid overload, because when you have too much sodium, you keep water in the body. Everyone knows that. So it may contribute to this fluid accumulation. So in my unit, we have moved to balanced solutions from the beginning because of that issue of sodium overload.
Yeah, this is totally in line with our very recent meta-analysis that we published in diabetic ketoacidosis, when we compared when it was done with saline versus balanced crystalloid. That was a clear, significant difference. However, we are about to submit another meta-analysis, intraoperative use of saline versus balanced solution. And in the operating room, they don't give as much fluid as for diabetic ketoacidosis. So the difference is not that obvious, or those statistically significant, but negligible. So both the sodium and the... So that
is for the meta-analysis. It's very interesting, and it's very reassuring that you indeed show what is expected: less fluid, and of course, less differences.
Yeah.
What is your opinion on that sodium accumulation? As you know, it's very much emphasized by some friends like Manu Malbrain and Niels van Regenmottel. What's your opinion on it?
Well, sodium accumulation is not good. Full stop. So physiology is best. So whenever we reach physiological values is best. And sodium accumulation is obviously no good. But again, we only found a minute increase in the total serum sodium in both analyses. So I was very much against saline, like a religion, as you said, right? It's really, I was very much against saline in all conditions. It's like the fluid of the devil. But now I have to change my mind in the view of the facts. In fact, our results contradict my prejudice and hypothesis. So if you give just a few liters of fluid, a couple of liters of fluid, it doesn't matter really what you give. And we have a lot of neurotrauma patients in whom it is necessary to give saline. So regarding Manu's fluid accumulation or sodium accumulation, so now he treats it very often as a religion as well, right?
Indeed.
He's not he wasn't the chair of the World Society of Abdominal Compartment Syndrome for nothing, right? So,
for sure.
Okay, well, any questions there? Xavier, thank you very much. And I am grateful for the Center of Translational Medicine here at Semmelweis University, and also for the Department of Anesthesia and Intensive Care to host this session. And your lecture will be available on YouTube, is that right? Shortly, and we will keep you posted, and all the others. So thank you very much for giving this talk for free, everybody, and all of them in front of the screens, and all of you guys here. Have a nice evening, and Xavier, thanks again. See you soon.
Thank you very much.
Much appreciated. Bye-bye.
Ciao, ciao.